Good afternoon, everyone. Thank you for joining PHCA for today's webinar, Livanta BFCC-QIO Appeals, Quality of Care, Complaints, and Provider Responsibilities. I'm Wendy Johnson with the Pennsylvania Healthcare Association. Before we begin, I have a couple of housekeeping items to cover. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from experts on current trends and practices, and to gain a understanding of practical application tools to equip you so that you may continue to provide the highest level of quality care possible. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for PHCA members. Credits will be uploaded to NAB within the next 2 weeks for those who have provided us with your unique NAB number. I'll be sending a link to a quick survey. Your feedback is important to us and our speaker, so please take a moment to complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, please feel free to submit questions using your questions pane on the right hand of your screen, and our presenters will address them at the end of the presentation today. Now for today's webinar. Today's webinar is being presented by Bryan Fischer, Communications Lead at Livanta. He will be joined by Lisa Novak, Kim Storms, and Gina Westfall. Bryan will provide more information about Livanta, the QIO program, and the appeals and quality of care complaint process and information resources available to PHCA members. It's been a few weeks since the transition from KeyPro to Livanta, and participating in today's webinar will give you the opportunity to better understand the review process and ask questions. Bryan will also be sharing important information about Medicare required patient notifications, Memoranda of Understanding, and provider best practices. I'll now turn the webinar over to Bryan.
Thanks, Wendy. It's a real pleasure to be able to join all of you today. I would like to just, again, say my personal thanks to Wendy for helping to make this possible, and to all of you from Pennsylvania who are joining. I am a native of the Baltimore area. I grew up in Timonium, Maryland, home of the Maryland State Fair, and just a few short miles from the Mason-Dixon line. So Pennsylvania holds a place near and dear to my heart. Spent a lot of time there. And if anybody is joining us from the Hollidaysburg area, you can email me later to find out my Hollidaysburg, Pennsylvania story. So anyway, thanks again to PHCA for allowing us to be here today. I'd like to just begin by going over a couple of the things that we're going to be talking about today. So if you are new to the quality improvement world or to the Medicare world, we're going to be talking about Livanta's role as the Medicare Beneficiary and Family-Centered Care Quality Improvement Organization. BFCC-QIO, as we call it, the Beneficiary and Family-Centered Care Quality Improvement Organization. So BFCC-QIO. It's kind of a mouthful, whether you say it all out or if you just use the acronym. So we're going to talk about that. Then we're going to talk about the Livanta's processes for appeals and the Quality of Care Complaint Program. And then we're going to leave you with 3 action items, so 3 sort of takeaways to go back to your facilities with to help ensure that you are in compliance with Medicare regulation and that you are using the best practices that we're going to be talking about today. So for those of you who are new to the quality improvement world, again, welcome. Livanta itself is somewhat new to the quality improvement world. We've been around since 2004. However, in 2014, when we were celebrating our 10th anniversary, we were awarded the very first, what is called, the BFCC-QIO contract with Medicare. That was what we call the 11th Statement of Work, and it began in August of 2014, and it recently ended on June 7th of this year. On June 9th of this year, we began what's called the 12th Statement of Work. So this was our first time being an incumbent QIO, Quality Improvement Organization, and we were awarded a contract to service 27 states and territories across the country. And so we will be with you until 2024. Now, we previously had served Pennsylvania in a similar, very nearly identical capacity for the last 5 years. However, some things have changed, and we're going to talk about that a little bit more as we go along. But this contract cycle, as I said, we are going to be working with 27 states and territories, which is responsible for about 68% of the national case review volume. And we work directly with almost 20,000 provider partners across all of those states and territories. So what exactly are we talking about when we are talking about a QIO, or a Quality Improvement Organization? Well, the history of the QIO program is actually fairly interesting. Take my word for it. The QIOs were first created in 1972, so they are almost as old as Medicare itself. And as they began, they quickly discovered that there was a larger role for the QIOs. And so they were expanded in 1982. And at that point in 1982, there was essentially one QIO, or Quality Improvement Organization, per state and territory. So technically, there were 54 QIOs across the United States and its territories. In 2002, the program was renamed to be called the Quality Improvement Organization Program, or the QIO program, as we all call it. And then in 2014, probably the largest change that has ever occurred in the QIO program happened. And in 2014, we went from having a single QIO in every state and territory to having essentially two QIOs, two types of QIOs. The BFCC-QIO, which is Livanta and our peer organization, our colleagues at an organization called QIPRO, and then the QIN, or the Quality Innovation Network QIOs. So the program was essentially split in half, and that was because essentially what Livanta and QIPRO do as a BFCC-QIO is primarily case review. So we work on behalf of Medicare patients and their families to review cases, but we also have another set of discrete tasks that we do to ensure quality improvement, and we partner with the Quality Innovation Network, so the QIN QIOs. There is a QIN QIO per every state and territory. We work very closely with the QIN QIO in Pennsylvania, and we're going to talk a little bit more about that in a second. But in 2019, so beginning on June 8th of this year, the QIO program underwent what is called the regional realignment. So many of you may be familiar with CMS's regional map. So historically, the Health and Human Services and Medicare has been divided essentially across 10 regions around the United States. Those regions are based out of the major cities. So Pennsylvania is part of Region 3, which is based out of Philadelphia. The other regions are Region 1, which is headquartered in Boston, Region 2, which is headquartered in New York, Region 4 is in Atlanta, Region 5 is based out of Chicago, Region 6 is based out of Dallas, Region 7 is in Kansas City, Region 8 is in Denver, Region 9 is in San Francisco, and then Region 10 is in Seattle. So for this contract cycle, Livanta was awarded Region 2, 3, 5, 7, and 9. The rest of the country either retained QIPRO as their QIO, or essentially were changed over from Livanta to QIPRO, or vice versa. So the real critical change for Pennsylvania is not that Livanta is essentially a new QIO for Pennsylvania, but there is a new phone number. So previously, the QIOs, the BFCC QIOs, were cut into essentially regions that we called QIO areas that did not necessarily pertain to the Health and Human Services map. So Pennsylvania used to be part of what was called Area 1, which included the other Mid-Atlantic states of New York and New Jersey, as well as New England. Well, Area 1 has gone away, and so we've realigned to the Medicare region. So Pennsylvania has always been part of Region 3, and it is once again. But that means there is a new phone number for Pennsylvania. We will talk about that in just a little while. So the QIOs themselves handle a discrete set of tasks for CMS. And those tasks are composed primarily of case review. So the largest volume of case review that we handle for Medicare are appeals. So these types of appeals are essentially they are discharge appeals. So when you are if you've got a patient and they're in the bed and they don't want to go, they are appealing that decision to Livanta. There are 4 major types of appeals that we handle. By far and away, the largest volume of appeals that we handle are what are called Weichert appeals. Weichert appeals originate both from original Medicare patients and their families, as well as Medicare Advantage plan holders who are appealing their discharge from hospital or from a long-term care facility. The next largest number of appeals that we handle are what are called BIPA appeals. BIPA appeals originate specifically from original Medicare patients who are appealing their discharge decision from either home health, skilled nursing, hospice, comprehensive outpatient rehab, or swing bed or critical access hospital services. A growing number of appeals are what are called Grijalva appeals. Grijalva appeals originate only from Medicare Advantage plan holders who are appealing their discharge from either a skilled nursing, home health, or comprehensive rehab facility. And then finally, the smallest number of appeals we handle are what are called HIN appeals. HIN appeals originate exclusively from original Medicare traditional fee-for-service patients who are appealing their HIN notice that they were delivered at a hospital. So to give you an idea of the kind of case review volume that Livanta handles, from 2014 to 2019, Livanta processed from start to finish over 300,000 cases. And of those 300,000 cases we received in the last 5 years, nearly 250,000 of them were appeals. So that is a significant volume of calls. In the 5 years that we had the contract previously for our area, which only represented about 48% of the country, we received over 2.5 million phone calls in those 5 years. So that case review volume is significant, and the vast majority of those case reviews we handle are appeals. The other kind of case review that we handle are what are called quality reviews. Quality reviews fall into 3 main categories. Probably the most common are simple, traditional beneficiary complaints. That is, if a Medicare beneficiary or their family or representative has a complaint about the care they received, they have up to 3 years after the care was received to file a complaint about that care. The other types of cases that we handle are immediate advocacy cases. Immediate advocacy is essentially an informal dispute resolution service. That is to say, if a patient is dissatisfied or has some other kind of gripe, essentially with the care they are receiving, they can call us, and we will advocate on the behalf of the patient or family or representative to try and hash out whatever is going on to try and alleviate the concern for the patient. And then finally, we also conduct what are called general quality reviews. General quality reviews are a little bit different. They are somewhat rare in that, if they originate from the patients, they are anonymous. However, general quality reviews also may include what are called focus reviews, CMS special studies that are ordered on behalf of Medicare. Also, they are typically handled, or they are also created through referrals from the QIO, which in Pennsylvania would be Quality Insights, and then also from referrals from state agencies. Oops, clicked the wrong thing. So on the provider side of things, we also provide a number of services to our provider community as well. So the first on the list is what we are doing right now, which is compliance education. Livanta, as your QIO for Pennsylvania, is available. I am available to provide additional education, supplemental education about any element of the quality improvement program through Medicare, or the tasks that are performed by Livanta as your BFCC-QIO. So I'm able to do this for your individual facility, but I'm also able to do this for hospital or for healthcare chains or larger organizations. It's not a problem. We want to make sure that we are a resource that's available to you, that you know that you can call us, you can ask us questions, and if you've got new staff that are coming on board, we're happy to train them in quality improvement. We can do a similar curriculum to what we're doing right now, or we can generate an original curriculum that is going to meet your individual needs. So that type of education is available to you, but we also monitor and we produce what are called the Memoranda of Agreement. So the Memoranda of Agreement is a document that is required by all institutional facilities that participate in Medicare. So if you are a hospital, hospice, comprehensive outpatient rehab facility, skilled nursing facility, or a home health agency, you are required under Medicare regulation to have an MOA, a Memoranda of Agreement, between your BFCC-QIO and your facility. And that is something that we do for Medicare, and we monitor the compliance for that. And we'll talk a bit more about that later. Now, I mentioned just a few minutes ago that there is another type of QIO that operates within Pennsylvania, and they are called a Quality Innovation Network, or a QIN, or QIN-QIO. QIN QIOs typically work more directly with providers on specific quality improvement tasks, like care coordination or diabetes care, medication safety, or public health promotion. Now, we share some of these goals with the QIN QIO. So where our goals coincide are a couple specific things. So reducing 30-day readmissions is a major task for both the QIN QIOs and for the BFCC QIOs, as is improvement in care coordination and general public health promotion. So I did mention, you may know them, it's an organization called Quality Insights. We work very closely with them, and they've got some offices around the state, but they've got representation in Central PA as well as in Philadelphia and in Western PA as well. So we work very closely with them on a number of projects. You may have seen last year we worked with Quality Insights to put on a Medicare Advocacy Symposium in Philadelphia last year. So we do work with Quality Insights very closely. But just so you know, for your information, the QIN QIO contracts are currently in their sunset phase. So like the BFCC QIOs, their contracts are for 5 years. So their current contract they're operating under really is in the last just couple of weeks at this point. We are currently waiting from on CMS to announce who the new QIN QIOs will be. We don't know at this juncture. However, as soon as we do have any information, we will pass that along as soon as we hear something. So, and Quality Insights will as well. So you may have worked with them before. So, back to the sort of the tasks that we perform for CMS. So, as I mentioned earlier, by far and away, the largest number of case reviews that we handle are for appeals. So on your side of the coin, it's really important that we go through this list and make sure that everyone is sort of on the same page here. So when you are getting ready to discharge a patient, it's required that you deliver what's called a Notice of Medicare Non-Coverage, or what we call the NOMNC form. Sometimes I've heard it called the NOMNC form. So the NOMNC form needs to be downloaded directly from CMS's website. So the website you see here is it's cms.hhs.gov/BNI, Bravo, November, India, BNI. BNI stands for Beneficiary Notice Initiative. And CMS really did a great job setting up this website. It's a tremendous resource for all of you as providers. And what it essentially is, it's a clearinghouse of all of the Medicare patient notices that you would ever possibly need. And there's quite a few. And they've got it broken down by, it'll show you, okay, what type of facility should be issuing this notice, what point should this be issued, et cetera, et cetera. So there's a lot of really good information here. However, it is a best practice to always make sure you are downloading the forms directly from the BNI website. And the reason for that is because CMS does update these forms from time to time. It's fairly infrequently, but they do. And if they do, they will notify us to notify you. But a best practice is to make sure you are always downloading these forms, because a requirement under Medicare regulation is to be delivering the most up-to-date version of this form, of any form that is to be given to patients. And so when you are downloading this form, so if you're working with like your IT folks, maybe they can set it up so it's an automatic download into the electronic medical record or some other system, but it really is a best practice to always download this directly from CMS. When you are updating it, the NOMNC must include Livanta's helpline and our TTY line number. Other QIOs may have given guidance in the past that you could put a website or a fax number or some other information there. All Livanta requires is that you have our name and our phone number, our main helpline, and our TTY line. The TTY line being a system for the deaf and hard of hearing. The form is electronic, so when you are if you are editing it electronically, you need to make sure that the font is no less than 12 point. You are also permitted to add your individual logo at the top, provided you don't shift any text onto page 2, or even worse, that you accidentally create a page 3. So in terms of the requirement for this notice to be delivered, it has to be delivered at least 2 calendar days before covered services end, or the second to last day of service if the care is not being provided on a daily basis. And this applies both to Medicare, original Medicare fee-for-service patients, as well as Medicare Advantage plan holders. So again, at least 2 calendar days before covered services end, or the second to last day if the care is not being provided on a daily basis. So I have here for you an example of a NOMNC form. So it's highlighted here just so it's a little bit easier to read. Obviously, you don't have to do that. This is an example from a provider in California. So you can see it's the Sacred Heart Skilled Nursing Facility. They've got their address here in Valley Village, California, their phone number, as well as the patient name and the patient's unique identification number. But I think critically here, what you see is that the effective date for coverage, your current skilled nursing care, so the type of care that is reducing or ending, and the date that it ends. And here you can see the top of the second page the bottom of the first page, bottom of the first page has the spot for the QIO information. So it says call your QIO. You can see it says Livanta LLC, which is our name. It's got this would be our California helpline number, as well as the TTY line. On the second page, you'll see there is additional information that you can fill out. So there is, if the patient in this case is a Medicare Advantage plan holder, so the hotline for the Medicare Advantage plan is here, as well as the name of their Medicare Advantage plan. And then finally, there is a box called additional information. This is really up to you how you want to utilize this space. You can put additional information in here, like, so for example, here they've opted to put in the contact for the, looks like the care transitions team, so like a discharge planner, gives their internal extension. You can call them, or you can copy and paste the information out of the detailed notice of discharge. You can put that right in here if you'd like, but you cannot use this space in lieu of the detailed notice. So you have to use you still have to issue the detailed notice, but you could copy and paste that information in here. Whatever you think is going to be the most useful for the patient and their family, you should be using this box for. So when you're working with caregivers, it's important to remember that the patient themselves may file the appeal, as well as any direct family members, any caregivers, any relatives, friends, neighbors, uncles, cousins, friends, roommates, former, roommate, anybody can file an appeal on behalf of a patient. It's really important to remember. You don't have to be a direct relative as long as you're in a caregiver role. You do not have to be a family member to file the appeal. All appeals must be initiated through a call to Livanta's helpline. So in the past, we had a fax number, and it was somewhat rare, but you could fax in an appeal if you wanted. Going forward, that option is no longer available, and when you file an appeal, you do need to call us. And when you call us, you'll speak to one of our live intake specialists. You will also have the choice, if you so choose, to leave us a voicemail. If you decide to leave us a voicemail, you're more than welcome to do that. However, multiple voicemails are not necessary. If you leave enough information, so a direct callback number, patient name, patient date of birth, Medicare number, give us all that information. We will get the appeal rolling and then call you back. What is not helpful is if you leave us 19 different emails with very little information in each one, because essentially we have folks who are working in our intake center whose job it is just to go through those voicemails. And so leave us one detailed voicemail, that is if you're calling during business hours or after business hours, and we will call you back. So you don't need to repeatedly call us or repeatedly leave voicemails. Now, if you're working with a caregiver and they are not a direct relative, if that caregiver would like to be privy to the information that is going to be coming out as a part of this case review, we're going to write an outcome letter that's going to have PHI, protected health information in it. If that caregiver would like to be privy to that information, they do need to complete what's called an appointment of representative, or an AOR form, appointment of representative form. It's a standard Medicare form. It's Medicare form CMS 1696, CMS 1696. You can download that directly from Livanta, or you can download it directly from CMS. Just Google CMS 1696 and that form will come up. You can just send that form into, the caregiver can send us that form, and we will get them noted in the file that they will be then privy to the protected health information that is going to go along with this case review. So when the beneficiary or their representative calls us, the first thing that we're going to do is offer foreign language interpretation service. Livanta, we employ an interpreter service that supports over 200 languages. So if you are working with a family for whom English is a challenge or not possible, that is not a problem for us. All you have to do is give us a call and be able to enumerate that the language that is necessary. So if the family speaks Swedish, if you can say Swedish, need Swedish, then we will we'll bring on a Swedish interpreter, and we will conduct the conversation in that language. And then from that point out, the case will be flagged in that language. So next time we need to make a phone call, we'll bring the interpreter on ourselves, and then have that person there to interpret the phone call. And then any correspondence, any letters will also be in the language of choice. So after the patient, we do that, then we will verify the patient, verify the patient's status. What does that mean? So that is, we're going to call you and say, okay, Mrs. Johnson wants to appeal her discharge. We need to make sure that, one, she is actually a patient in your facility. Two, has she gone past her scheduled discharge date or time, date and time. Once we determine that the patient is still, admitted, they're still there, and they haven't gone past their scheduled discharge date and time, we will then request the medical records by fax. We are currently transitioning into a new fax system for medical records. Some of you may have seen it. It's been partially rolled out. It has not been completed yet. But going forward, you will see our fax cover sheets are now going to contain a barcode. And it's critical that when you return a fax to us, that you include that cover sheet on top, because it has that barcode on it. That barcode is keyed directly to that patient's record within our case management system. And that is going to, so when you send that fax in, our fax machine is going to read that barcode and automatically deposit those, the materials you sent into that patient's file in our case management system. So if you to expedite the service, you need to make sure that you are returning that fax cover sheet with the barcode on it, if you got it. As I said, that has not been, the changeover to that new medical record system is not complete. So some of you may be receiving it and some of you will not be. But within the year, we will be completely moved over to that new system, and you will start seeing those medical record requests with barcodes. So remember, whenever you're sending us something, make sure that the barcode cover sheet is on top. So once we have everything, when we've got the case all ready to go, we'll notify the patient of any potential financial liability, and then we will assign the case out to one of our physician reviewers, who will then return that decision within 24 to 48 hours. The physician reviewers, the goal is 24 hours. It's typically the requirement in most cases. There are some instances where we may have up to 48 hours, but 24 hours is our goal, and we meet that goal most of the time. And then, so after we have the outcome, we will notify both you, the provider, as well as the patient and their representatives by phone. So we will call you and we'll let you know, okay, here's the case, here's the outcome, here's what the review was, and we'll let the patient know, we'll let you know. Similarly, we'll also send you a faxed copy of the outcome letter that our physician reviewer composed, and then for your records, we'll also send you a hard copy by mail. So all of our physician reviewers are independent physician reviewers that work for us here at Livanta, and they are by requirement. They are all board certified and actively seeing patients. But to ensure that essentially that the right person is making the review, we do what's called a geographic match, because we understand that healthcare is delivered differently from state to state. State borders are real. I have a very dear friend who lives in Pittsburgh, and she will tell you that, not to cross the river and go into Ohio. But I think it's got some Steelers Browns overtones there, but there are differences. The state laws are different, and the way medicine is in healthcare is administered is different from state to state. And because of that, we will make sure that a Pennsylvania doctor is reviewing a case from Pennsylvania, because they have an inherent understanding of the healthcare environment in Pennsylvania. If necessary, we'll go one level beyond that, and we will conduct what's called a specialty match if we need to find a specialist. So the physician reviewer's job for appeals is solely to determine if the discharge was medically appropriate. Once they do that, they will write what's called the outcome letter, and then they will give that information to our registered nurses here in our call center here in Maryland, who will then make the call out to both the provider, the patient, and if necessary, the Medicare Advantage plan. If the beneficiary or their family member chooses to withdraw their appeal, they may do so at any time. However, they do have to do so in writing. So they're probably going to be asking to borrow your fax machine at that point. If you need to cancel the discharge, so if the patient's condition changed, or if there's some other type of change where the discharge is no longer necessary or appropriate, if you need to do that and the patient has an active appeal with us, what you need to do is put that information on letterhead, just in a note, saying, Mrs. Johnson, has developed the flu, and it's no longer safe to discharge her home. Therefore, we are canceling the discharge, and the appeal should be suspended or, withdrawn. Just put that on letterhead, fax that into us, and we'll take care of it. It's all you have to do. Now, I did mention earlier the detailed notice of discharge. So this is an additional requirement to be delivered. So if the patient or their family member has appealed their discharge, the detailed notice or DNC form must be issued. And this form is particularly helpful for a number of audiences. So the Livanta physician reviewers, find this to be a very, very useful document. And specifically because this form, when it's written well and in plain language, it lays out very specifically why the discharge is ordered. It's much easier for our docs to look at this form and then look at the medical record and then say, okay, I understand what these guys were going after. I get it. rather than the doc trying to intuit that information from the medical record or scattered notes within the medical record. The DNC lays it out in plain language exactly why the discharge is being ordered. It works well for the patients and family, again, because if you write it in plain language, it helps the family and the patient to understand exactly why it is that they are being discharged. And it may cause them to withdraw their appeal. We have seen this in the past. But long term, I think what's really helpful about the DNC is that it helps the patients and their families to increase what we call their health literacy. So health literacy is what we consider to be someone's understanding of the healthcare system. A perfect example of this, my dad is going to be mad at me because I always use him as as my storytelling device. But last year my dad was in the hospital. He's doing great, by the way. He was in the hospital. And came time to, I got the call saying, come get your dad. Time for him to go home. And so I spoke to the discharge planner, and they had home health arranged and everything. It was all going to be great. Well, I went to go get my dad from the hospital, and he was pretty grouchy, more so than usual. And he, and I said, well, aren't you happy to be going home? He said, no, I still feel terrible. And I said, yeah, I know. You're supposed to. You're not supposed to skip out of here. We're going to wheel you out, man. Maybe we'll pick out a nice, fun colored wheelchair. There's one over there that's red. I mean, that's kind of sharp. But we're going to wheel you out. You're not supposed to feel great, but you don't need to be here in the hospital anymore. When you get home, the home health nurses are going to check in on you. And I think that made him feel better, but I think he had this kind of outdated notion of what hospital care meant, that he was going to be in the hospital until he felt good. And the answer is we all know that that's not true. You're in a facility until you don't need to be there anymore. And so a lot of folks need help, understanding and becoming more, I think, better educated about the 21st century healthcare delivery system. So here is an example for you. Now, this is from a hospital, and that's simply because that was what I had at hand when I was putting this presentation together. But this is an actual detailed notice of discharge. As I said, it is from a hospital. But the reason I like this one is, first of all, it's extremely well written. So you can see the boxes checked says, Medicare no longer covers these services, and then specific information about your current medical condition. So it says, you were admitted to the hospital, care, treatment, asthma, COPD, exacerbation, overlap. You underwent diagnostic tests, determined you had asthma with COPD, exacerbation, overlap. You received IV antibiotics and fluids. Your medical condition has been fully assessed and treated, period. Your pain management, blood pressure, heart rate, respiratory rate, and temperature are now stable. And my favorite sentence in this whole thing, you no longer require constant 24-hour-a-day treatment and monitoring, including hospitalization management by physicians or assessment by licensed professionals. What this person, the excellent person who wrote this, did is they defined what it means to be in a hospital. And so unequivocally, the patient and their family can see exactly what it means to be in the hospital, and that they no longer require that type of care. And so we hold this up as an example of a really well-written DNC. It was useful for our doc, and it was useful for the family member, and it's useful in the long term for everybody. And what you see here is something that is not as useful for everyone. In fact, it's fairly, it's not good. So you can see that this is an actual DNC from a hospital stay, and you can see the provider, they did check off the box saying that so that is required to do that, and then they gave it to the patient and they put it in the medical record. And technically, that is what you're required to do. What they didn't do was fill out anything under the specific information tab. And, so technically, this is a technical, they did exactly, what they had to do, but they didn't do anything beyond that. And this is not helpful for our doc, who can't, has to now look at the medical record and try to intuit what this hospital's decision to discharge, why they were making that decision. and then the patient has no further information. So, this is just an example of, I wanted to show this to you because I think this really represents the range of, of detailed notices, but I hope this is a useful, just a kind of a useful example for you to see what folks are experiencing out there. So the last type of case review that we handle are quality reviews. So the largest of those are complaints. And as I said earlier, patients and family have up to 3 years to file a complaint about care they received. And when the patient files a complaint, the administrative procedure, it begins fairly similarly to the appeal. So they'll call Livanta's helpline, but then it will diverge a bit. So there is a written requirement. The patient does have to write out why they are complaining and what their complaints are. But again, it does start with a phone call to us. Our physician reviewers are going to look at that case and try to determine if there were any quality issues at play there. But unlike the appeal, which is reviewed in 24 hours, complaints are typically reviewed over the period of between 30 and 45 days. The same physician reviewers who are conducting the appeal reviews for us are also going to review quality cases. But it's really important, I think, for everyone to remember that quality reviews that are performed by Livanta are non-punitive. We are not interested in taking money back. We are not interested in punishing anyone. Our goal as the QIO, as the Quality Improvement Organization, is to raise the quality of healthcare. So if we identify an area for improvement, we're going to work with you and we're going to work with Quality Insights to make sure that you have the resources necessary to correct whatever the issue may be and improve the quality of care for your patients. As of March of 2017, if a patient files a complaint and we do the review and we find there is no basis to that complaint, the patient, typically they're not happy about that, but now they do have a right to reconsideration. So they can ask us to have another doctor review that, which we will then hand that off to another physician reviewer who will essentially view that as a de novo review. They'll just do a brand new review as if the first one never happened. If we do a review and we have findings, you as the provider, you have up to 3 days to ask us for a reconsideration. So if we'll notify you by phone and fax as with the appeal. And if you say, no, that's not really what happened, I want to explain, you have up to 3 days to ask us for a reconsideration and send us additional information. So same as the patient. The other types of quality reviews that we handle are called focused reviews. These focused reviews are typically in the form of special studies that are either initiated directly by Livanta or they are initiated by CMS and conducted by Livanta on their behalf. Usually, focused reviews are for specific quality or compliance checks. Just like a complaint review, they are non-punitive and they are always retrospective. Last year, 2018 into 19, we conducted compliance checks for hospital providers to make sure that they were issuing the important message from Medicare, which is the hospital version of the NOMNC form. And we found that there were significantly high numbers of hospitals that were not issuing the IM notice properly. And so once we did that review, we conducted remedial education for those facilities, and then we developed a curriculum that we provided to the various hospital associations across our states and territories at that time. And then finally, general quality reviews. These are, again, fairly rare. Typically, if a patient calls us and they want to remain anonymous, they say, hey, I had this really bad experience, but I don't want you letting the hospital know or facility know why I called or that I called. And we'll select a medical record, we'll select the medical record and review it to see if there are any findings. We will only share that if we do have findings. We will only share that with the provider, and that is because of privacy laws. But again, these are non-punitive. So all we are interested in is if we have any findings, correcting those issues and giving you the access to the resources and help that you would need to overcome whatever those issues are. And then finally, we do have a new program, relatively new, called Immediate Advocacy. This is essentially, I mentioned earlier, like a dispute resolution service. So if a patient calls us or a family member calls us and, they've got a complaint, if they are still receiving services, they can ask us to advocate on their behalf. And if we can try and hash out whatever issue the patient or family member is facing, a lot of this is really just education. We find that patients have significantly higher rates of satisfaction with the outcome of these immediate advocacy reviews. All of our patient advocates are social workers or nurses, and they each have a 10-day window to try and resolve whatever the issue the patient is facing. So this is relatively new, and it is offered to everyone who calls Livanta. So whether you call us for an appeal or quality of care review, you are offered the opportunity to take advantage of the Immediate Advocacy Program. Now, way back at the beginning, I did mention that a Memorandum of Agreement, or an MOA, is a requirement. So we're going to talk about that real quick before we wrap up. So as I mentioned earlier, an MOA is required if you are approved to receive reimbursement under Medicare. The MOA is a very simple document, and all it does is establish the legal relationship between Livanta and you as a provider that participates in Medicare. It is a requirement under Medicare law. Now, many of you, most of you hopefully, had an MOA signed with us previously. Unfortunately, those MOAs are now invalid. So if you signed an MOA before June 8th of 2019 of this year, you will need to do complete a new MOA for us. The MOA now has 4 points of contact that we track for each of your facilities through the MOA. Probably the most important is the appeals contact. Next is the medical record contact for cases other than appeals, general QIO liaison for cases other than appeals, and then finally a remittance contact. There are certain instances where we are able to reimburse you for pages and postage. We'll let you know if you are eligible for that, and if you are, just let us know where and to whom to send those reimbursement checks. So again, if you haven't done your MOA, if you did one prior to June 8th of this year, you will need to complete a new MOA. That is a requirement. And we are going to be conducting a compliance check within the next couple of weeks to determine who has completed and who hasn't completed their MOA. And we will be working with Wendy and her team to notify you guys if you have not completed your MOA. But another tool that we offer, a service that we offer for you as a provider, is called Arrow. If you're not familiar with this, Arrow is Livanta's online case lookup tool. We were actually the first QIO in the country to create a system like this. When you create a case with Livanta, you'll get a case number. And all you have to do is go onto the website, which is LivantaQIO.com, and click the Check Your Case button and put in the case number, and you'll see exactly where your case is in progress. This is updated live to our database, so whatever you see here is exactly the status of the case at that moment. It's accessible 24 hours a day. You don't need any kind of login information or anything like that. It's very, very easy to use. There's no PHI or PII displayed. Now, we recently added the Arrow tracking tool to our smartphone app. So yes, Livanta has a smartphone app. It's available to you on the Apple App Store or the Google Play Store if you're an Android user. So we received feedback directly from our provider partners, actually specifically from a social worker, who said that she carried her iPad around with her when she went and worked with patients, many of whom had filed appeals. And so it was an easy way for her to just pull up the app and to type in the information, the case number, to check on the status of the app right there for her patients. So we added the case tracking tool to the app. We also added the Medicare Rights Reviewer. So if you're a social worker or a discharge planner, you can use the Medicare Rights Reviewer to help patients understand what their Medicare rights are vis-a-vis their individual situations. But we did all of this based on feedback, which is why there is a practicum. Congratulations, you win. So the practicum today is, if you're not already looking at your phone, I won't tell. If you're not already looking at your phone, take out your smartphone or tablet. If you're on an iPhone, open the App Store, or if you're on an Android device, open the Google Play Store and search for the word Livanta. That's Livanta, Livanta. And in case you were wondering, we say Livanta. We're all from this general area. We kind of talk through our noses a little bit, so we pronounce it Livanta. They're out in California. They're fancy. They call it Livanta. But we're here in Maryland. We just call it Livanta. So search for the word Livanta on the App Store or Google Play and download and install the app. It's free to download. It's free to use, but we need your feedback. We would like to know, one, is the app working? Is everything working? Is there anything that's broken? But two, I think more importantly, is this an added benefit to you? Are you getting good use out of it? Is there a feature you'd like us to add? Is there a feature you think is superfluous? We need to know what your feedback is, because this app was originally developed for patients, but we found that providers are actually using it more than patients and family are. So we really depend on the feedback we receive from you to determine how well we are doing. So your takeaways for today, if you haven't already done so, please complete your new MOA. Please get that into us as soon as possible. Just go onto our website, LivantaQIO.com, select the Provider tab, and click the MOA link. If you haven't already done so, update your Medicare beneficiary notices to include the new phone number for Pennsylvania, and then update your internal procedures to include an annual review for the contacts on your MOA. People come and go from jobs all the time, and it's important that we are always calling the right person, the right phone numbers, and sending emails to the right folks. If you would like to go onto our website, again, it's Livanta QIO. You can, LivantaQIO.com. You can download all of our provider bulletins there. We publish provider bulletins semi-regularly, and we will send those out to you directly. Also, you can find us on all of the major forms of social media: Facebook, Twitter, Instagram, and LinkedIn. And we post regular updates there that may be useful for you. So we ask if you could follow us, we'll follow you. If you haven't already done so, add yourself to our email list. You will receive provider bulletins and other critical updates directly from us. Just go to LivantaQIO.com, select the Provider tab, and then select the Provider Bulletin and Download tab, and there'll be the email form right there that you can just sign up for, and we will make sure you always will get all of our provider mailings. We promise not to send you a lot either. We're only going to bother you when we absolutely have to. So my information is here. Wendy's going to send this out to you later. Please always feel free to shoot me an email. You can call me as well. I'm not always here in the office, so if it's a time-sensitive or case or a clinical matter, you do need to call the helpline. The number for Pennsylvania is 888-396-4646. Again, it's 888-396-4646, and that is the helpline, whether you are a provider or a patient. It's open Monday through Friday, 9 to 5, and then 11 to 3 on weekends and holidays. So I need to take a quick breath and blink a few times, but at this point, I'm going to turn the Q&A session back over to Wendy, as well as to two people who know a heck of a lot more than I do. Kim Storms, who is our Quality Assurance Manager. Kim is an expert in Medicare's regulatory environment, and Gina Westphal is one of our patient advocates. So these two know way more than I will ever know about this material. So the question and answer is going to be handled by them. So Wendy, if you could go through the questions for Kim and Gina, I will stop talking for just a moment.
Great. Thank you, Bryan. That was a lot of great information that you shared with us today. There are some questions that are already in, but for those of you on the line on the webinar, if you have any questions, please feel free to type them into the question pane on the right hand of your screen, and we'll go into the questions in just give us maybe 30 seconds to allow some time, and then again I'll ask the questions that are already in the question box for the ladies to address. Okay, I'll start with the first question. To clarify, a skilled nursing facility staff member can file an appeal.
That's correct. Anyone can file an appeal on behalf of the patient. So oftentimes in a skilled nursing facility, it's someone from the social services department, but it doesn't have to be. It can be a floor nurse. It could be a nursing assistant. It can be anyone that the patient trusts, to call us and start the appeal.
Great, thank you. Let's go on to the next question. If a Medicare Advantage member from Pennsylvania, where Livanta is the provider, or let's call it provider, receives services in another state like Florida, where KeyPro is in play, which QIO would handle the appeal?
Florida. The appeal is always where care occurred and not necessarily where patients live. As you know, this generation, or this population, I should say, a lot of them are snowbirds. So that's a question we get all the time, but it's always where the care occurred.
Makes a lot of sense. Are there any other questions? There aren't any other questions in our box, but I'm sure there's other questions that you have. And again, I will be sending Bryan's contact information. You can feel free to reach out to him at any time. I know I'm always driving home, and I think of something on my drive home that I thought I should, that I should have asked earlier in the day.
Hey, Wendy, I think I had a quick question actually for my colleague Gina. Since Gina's a patient advocate, Gina, could you just real quickly go through an example of how immediate advocacy might, it might make someone withdraw their appeal?
Sure. So what we do with immediate advocacy, and again, it's not necessary to file an appeal. It's just that they need some help. We help patients identify what their concerns are or any challenges they're anticipating regarding their discharge. So we had a case of a gentleman who was 73 years old, had a stroke, and then had problems with functionality and ambulation. His concern was he didn't feel that he would be safe at home and might risk falling again because his home needed to be reconfigured for safety, and he didn't have appropriate DME. So what we did was we worked with the provider to ensure that he had a home safety assessment prior to his discharge. The home was safely reconfigured. There were some grab bars and elevated commodes and other things put in place for him. DME was delivered prior to his discharge, and he felt more confident about going home. He felt that he would be safer knowing that these things were in place, and as a result of that, he did withdraw his appeal.
Good information.
Great.
We do have
Thanks,
more
Gina.
questions that come in. Bryan, does that cover what you wanted to convey?
Yes, yeah, exactly. I just wanted to make sure everyone knew that, this was an opportunity for you. So if you're working with a patient, immediate advocacy is a route you can always try and take with us.
Okay, so here's another question, and I think you may have covered it just a little bit here, Gina. What do you do if you send an appeal and one physician overturns the decision of the Medicare Advantage, and then 1 week later nothing has changed and Livanta physician upholds decision? What do you do? Even though nothing has changed, the resident still has skilled needs that original Livanta physician overturned decision because of that. And for example, a vent.
Kim,
well, our physician's decision is binding. It's the QIO's decision, so it's the binding decision. You would just follow, whatever that was. If you felt that the patient needed to, if we said they could go and you feel that they need to stay, you can have them ask for reconsideration where it would be sent to a different physician. That's certainly always an option. And I hope I answered your question. I'm confused about upheld and overturned, and it's not you, it's me.
It's important to make sure that the beneficiary is aware that if he files a consideration appeal, he is not financially protected. as he would be in the first appeal. So that's important for him to understand.
Okay. There aren't any more questions. It sounds like that question was answered. The person who asked the question got the answer that they needed there. They conveyed thanks for that. And we do have another question. Is the patient liable for payment for services rendered if the denial is upheld during the first appeal?
So when the patient gets the results of the appeal, the patient is notified and the provider facility is notified. They have, once they get that the notification that the physician reviewer agrees with the discharge, then they will be discharged by noon the following day after notification. Any care provided to them, or if they decide to stay beyond that time frame, noon of the following day after notification, they will be responsible for that payment going forward.
Great, thank you. We'll give it another minute and see if there are any other questions that come in. These are great questions. Keep them coming.
I'll just add real quickly, one of the things that we do when we work with patients is every situation is different. And so there may be differences in liability. So, for example, if a patient, and Kim, correct me if I'm wrong here, but if a patient files their appeal, and they're, let's say, in the last, couple hours of their eligibility to stay, they do run the risk of financial liability during the period in which we are reviewing the case. We make sure that because every case is different, we make sure that we review any potential for financial liability with the patient or their representative before going through with the appeal.
Awesome, thank you. Well, I'm not seeing any more questions, and again, I will be sending out Bryan's contact information, so everyone will have it at your fingertips later today. I just want to remind everybody to complete the survey that I'll be emailing, and the recording of today's presentation will be made available on the PHCA website later today as well. Please take a moment to complete that survey, and just a reminder that our annual convention is coming up at the end of the month. Look for the convention session descriptions that will be coming out through our blog and through other email means tomorrow. It is on our website. If you're looking for it, just email me and I can send you a link to it if you're still on the fence on whether or not you are planning to attend that. There's still plenty of time to get signed up, so we're looking forward to seeing everybody at the end of the month in Valley Forge. Right now, I just want to thank Bryan, Gina, and Kim again for your time today and presenting on this really important topic. Again, just want to remind everybody that we do have other webinars that we are scheduling through the fall. We'll be back on track after the convention with a webinar on October 8th. We have another one scheduled for later in October and 2 in November and 1 in December. So keep an eye out, get signed up for those. Those are for credit. And we are always looking for timely topics. So if you do have anything that you want to share, again, shoot me an email and we'll look for a webinar speaker to cover the topic. Just want to wish everybody a great remainder to your day. Thanks for attending.
Thanks, Wendy.